I think we probably have just a few minutes. I want to be mindful of time for the wrap up that I believe is supposed to start in a few minutes. But I think if anyone in the audience has questions, please feel free to send them in to us, and we will do our best to handle them all. I did want to start by asking the panel a question around optimization. And we talk a lot about optimizing care delivery for quality and for certain outcomes. And the question is, how do you prioritize? Is there a hierarchy that the group thinks about in terms of what are the important outcomes? Because sometimes what we're talking about, and especially around supply demand, is that perhaps the demand for services is so high that it outstrips the need or the supply of providers in any particular areas, which then would impinge on quality. And so, how do you actually consider optimizing, outcomes, and how do you actually optimize, or how do you actually start thinking about, those kind of issues? So I'll just leave it open, and if no one answers, I'll call on you. So,
sure, I can take that one. So when we talk about optimization, I probably look at the specific service lines that we might want to optimize for quality. So we'll take emergency for an example, and we'll break it down into STEMIs. Some of our sites we identified early would have to call somebody in from home, or a respiratory tech, or somebody specifically to do the EKG, which would delay the time to EKG. So an education piece to cross-train other individuals that could do the EKG at the time of patient arrival, especially off hours at 3 a.m. So it probably would boil down to training, education, would optimize those outcomes so we can get the EKG earlier. In addition, from the technology standpoint, optimizing those types of things, it's also training, daily camera checks, checking the system, checking the glide scopes, making sure they're connected. So everything's prepared and ready to go when the critical patients come in. In addition, when we identify that more education might need to be spent, for example, if we've done a crike over the camera, or we cut the neck and they have a certain kit, and that's a procedure you might only do once or twice in your lifetime, we can bring in a surgeon or one of our emergency medicine specialists and provide a 45-minute CME topic just specifically on that, put it in our cloud to train the site, and tailor that education to them to improve their quality of care when they see those types of patients come in. So probably optimization would be identifying the gaps, for example, a delayed EKG or procedures that aren't routinely done, and educating and bringing that level of care up higher. Thank you.
Thanks.
So I think it's very nice comment from Dr. Cole, and I was thinking is that optimization is in many different levels and pretty specific. For example, if you look at inpatient statistics or the ED or ICU, you look at the length of stay, and you can look at the time that they are on they are intubated. The outcome in terms of if they get off the intubation earlier, do they have to be re-intubated, and what is the risk? And you look at the amount of drugs that is being used. And so that's in one type of things, right? But then if you look at the diabetic patient, then that's very specific. The outcome will be re-optimized. Is the level of glucose, blood glucose, that is being the non-fluctuation and being within the bounds as the doctor would like to see. So a very steady type of glucose level, and that will be a beautiful outcome. Right? So you are looking at the optimization itself will be quite different for different type of care. And the measurement and the metrics will be different. And that is extremely important, because there's the clinical care where you measure the outcome, like in the case where you can measure glucose. But in the case that you don't, you measure something else. So you can, it's not one objective fits all, and a lot of times it's multiple objectives also. And I think, like, for example, in the COVID-19 is an interesting one. So I happen to deal with a lot of the patient care where we look at many different outcomes because everybody is different. So in the high risk patients, then we would like to know what is the first sign of intervention to ensure or to prevent death, right, for those high risk patients. So all of those becomes your objectives, right? So then your objectives, in a sense, is very specific to different care. But my feeling is that optimization is throughout the whole spectrum. You have to do it because there is no way you could just say, well, look, we're going to do this without knowing what is the best route. And the best route has to be systems view also, and that makes the connectivity itself so important. So I think, I hope I answered the question, but like I say, it is pretty specific, and I'm sure every single doctor could tell you for their care, this is the objective, or these are the objectives, and that has to be optimized.
Great. We are a little bit past time, and I want to be respectful of our audience as well as our presenters. I'm going to kind of wrap up the conversation here, and just to let people know if they sent a question in on the chat box, we will address those questions and get back to you tomorrow during the session. There was one specifically to both Susan and to Leonie around percentage of veterans who use the platforms for bilateral communications. But let me thank the presenters for this very interesting and enlightening conversation around access and approaches to care delivery models.